So now I'd like to start by introducing our speaker this evening, Dr. Kadri with Ascension St. Agnes, Maryland Surgeons. Dr. Kadri is a board-certified a board-certified complex general surgical oncologist and general surgeon. His areas of expertise include diseases of the pancreas, liver, bile ducts, gastrointestinal tract, skin, breast, endocrine organs, connective tissue malignancies, and metastatic malignancies. He performs procedures both open and minimally invasively using laparoscopy and robotics. Dr. Kadri was inspired to become a surgical oncologist when seeing patients with complex cancers who required a multidisciplinary approach to treatment. He understands that cancer patients are in a fragile state upon diagnosis, and he spends his time helping patients understand their disease and how best to help them. His goal is always to recommend the best surgical approach and multidisciplinary treatment to help cure patients of their disease and improve quality of life. Dr. Kadri has published numerous peer-reviewed journal articles on cancer treatment and strives to apply the most recent and up-to-date medical information when treating his patients. Welcome, Dr. Kadri. Thanks so much for joining us this evening.
Thanks for having me, Kelly. When we were discussing when to do this webinar, I was obviously like, we have to do it in November because November is Pancreatic Cancer Awareness Month. And surprisingly, we had the option to do the webinar on today, which is 11/16/2023, and that's actually World Pancreatic Cancer Day. And so this day, essentially through multiple action networks for pancreatic cancer, multiple hospitals, they all essentially have information and webinars on pancreatic cancer, and we decided to do ours today. And for those who don't know, pancreas cancer's ribbon or color is actually purple, and you can't really see on the Zoom link. We were talking about this before, but my tie is purple right now. So hopefully you'll show your support with the purple. So just going through what we'll talk about in this talk, we're going to talk about what is the pancreas and essentially what is pancreatic cancer, different types of pancreatic cancer, understand common terms that are related to pancreatic cancer, and the multidisciplinary team that will be taking care of people who are diagnosed with pancreatic cancer, risk factors and symptoms of pancreatic cancer, how pancreatic cancer is diagnosed, treatment options, and prevention. So what is the pancreas and where is it in your body? So it's actually an organ or a gland that's sitting in your mid-abdomen, and it sits essentially just below your liver in the mid portion of your abdomen. And it has two major functions. It has an exocrine function, which means that it produces certain enzymes that help digest food, and an endocrine function, which means that it produces hormones that can regulate multiple aspects of your body. So from the exocrine standpoint, it helps with digestion of food. Your pancreas releases bicarbonate to help neutralize the acid that comes from your stomach with the food that's mixed in, and then it produces lipase, amylase, peptidases, and multiple other types of enzymes that help break down that food for digestion. The endocrine function of the pancreas actually produces hormones, and many of us have heard of insulin, and that actually regulates blood sugar, but there are numerous other hormones that the pancreas produces that can control a lot of your endocrine function, and that's why this organ is very, very important. So I have patients come into my clinic all the time, and they have an unfortunate diagnosis of a cancer, but they might see something on their pathology report, have heard something from somebody that said, wait a second, I have a tumor. I don't know if it's malignant or benign. It just becomes so confusing. So I wanted to start off the talk, and throughout the talk, we'll have some phrases and terms that people will understand, just so that you can better understand what a lot of the terminology is when we're talking about these, when we're talking about cancer, when we're talking about tumors, when we're talking about different treatment approaches. So really, what is a tumor? A tumor is just an abnormal growth of cells. And it's just like cells that have started multiplying in an area that are just growing abnormally. You can have benign tumors, which are tumors that don't spread, where they just grow into a certain area and they're localized, and they don't really have that chance of spreading to kill you. But you can also have malignant tumors, and these are the ones that are more concerning, where they're quote unquote invasive. Well, if you read on a pathology report or hear from somebody, or they're cancerous, which means that they have the potential to spread to other areas of your body and could kill you. So what exactly is cancer? We hear this term thrown around so many times, and many of us, just say, well, it's something bad, but that's what many people just know, that it's just bad. So really what cancer is is an abnormal, uncontrolled growth of cells that can spread throughout your body and could potentially kill you. And the word cancer itself is actually an ancient Greek term that was used for a crab. So Cancer the crab, if you know any type of astrology, was a crab that was designated that they saw in the skies, and they said, all right, well, this is a crab, we're going to call it Cancer the crab. And Greek physicians at that time saw patients with tumors, and those tumors that were quote unquote malignant, if they saw them spreading, they saw veins of the tumors outgrowing everywhere. And they said, wow, this looks like a crab. And this is where they decided to term those tumors, or malignant tumors, cancer. And that's where the term cancer comes. This was essentially then brought into, modern day medicine and the medical language around the 1600s. So what are the different types of pancreatic cancer themselves? So when you typically see a person, or you hear somebody who's diagnosed with pancreatic cancer, most of the time they're talking about pancreatic ductal adenocarcinoma, because this is the most common type of cancer. And in this talk, we're going to mostly focus on that, but I did want to touch base on the different types of pancreatic cancer, because there are many different types. Now, pancreatic adenocarcinoma, specifically pancreatic ductal adenocarcinoma, consists of about 90% of all pancreatic cancers that are diagnosed. And these typically come from the ducts within the pancreas, and they basically grow from around this area. Within another subset of cancers are pancreatic neuroendocrine tumors. Now, this is the second largest subset, and people say it's anywhere between around 5% to 10%, depending upon the literature you read. These essentially are tumors that develop from the neuroendocrine cells of the pancreas. And then there is a subset within that, or whether they're functional or non-functional, whether they can produce hormones, whether they don't produce any hormones. More than likely, most of them are non-functional, but there are, a certain component that can be functional, and that's a whole other topic on its own. Then there are another large amount of subsets of different cancers, such as adenosquamous carcinoma, acinar cell carcinoma, squamous cell carcinoma, and colloid carcinoma, which are all quite rare, but are components of pancreatic cancer. And then finally, there are also these precancerous lesions that you may see, and these are typically pancreatic cysts. Now, one of the most concerning ones that has the highest risk for potential, chances of malignancy are main duct intraductal papillary mucinous neoplasms. And you can say that like 2 times fast, but the acronym for it is main duct IPMN, or MD-IPMN. This specifically is a precancerous lesion. So it doesn't mean that you have a cancer, but you have about a 40 to 80% likelihood of this potentially transitioning into cancer. And then we're not really going to focus on this itself, but pancreatic cysts are their own topic. Really could spend like an hour on that as well, but it is something to be aware of. And so pancreatic cancer really is in the mainstream media. Many of us have seen famous people who are unfortunately passing away from pancreatic cancer, but you might see some people that are diagnosed with pancreatic cancer and they live for a really long time. And you might say, what kind of pancreatic cancer do they have? Typically, patients just die after they're diagnosed. So one of the most prominent examples is Steve Jobs. So he was diagnosed with a pancreatic neuroendocrine tumor, and neuroendocrine tumors themselves have a much slower progression. They're typically not as aggressive as pancreatic ductal adenocarcinomas. Those are much more aggressive, but really it's a slower progression. So typically, he was diagnosed in 2004, eventually underwent surgery a couple of years later, and then, unfortunately it did spread and then unfortunately take his life. But he lived through all of this, and you can see him, with cancer and then this unfortunate progression as it got worse. But he lived through it with all of this. Unfortunately, if you see somebody with pancreatic ductal adenocarcinoma, 50% or more of the time, they're being diagnosed at a stage 4 or spread of the disease past the area of the pancreas. And so Alex Trebek, when he was diagnosed with it, he was diagnosed in probably almost early 2019 and basically passed away in late 2020. So you can clearly see the distinct, basically, progression of each one of these cancers. And again, this is why we're going to focus on pancreatic ductal adenocarcinoma in this talk, just because it's so virulent and highly aggressive. So how common is pancreatic cancer? When you compare all of cancers that we see in the United States, really it's only the 10th most common cancer when you compare all of these other cancers, from breast to lung to colorectal. But at the same time, if you look at the amount of deaths that happened, it's the third highest cause of death of all cancer in the United States, with the first being lung and the second being colorectal. And I imagine in the next couple of years, possibly 5 to 10 years, it's probably going to overtake colorectal cancer as the second highest cause of death in the U.S. And it really only represents 3.3% of all new cancer cases in the U.S., but it's just so aggressive and really has an increased risk of death compared to all the other cancers. And even this poor prognosis, even with our modern medicine, I remember when I was in medical school doing research about 20 years ago, we were looking at this 5-year relative survival, and it was saying, I remember it was single digits. It was 6.9%. I remember 6.3% one time. And when you look at everything, look at how far we've come. We've almost doubled that in the past 15 to 20 years, but it's still so low. It's only 12.5%. And these are some, harrowing statistics that are just a little bit old now, but, I always like to put these up there because really it just shows how dangerous this cancer is and how aggressive it can be. It's, again, the third leading cause of cancer in the US. It's the first mortality rate amongst all cancers. Now it's probably about 89% die within 5 years of being diagnosed, 74% die within the first year. And then there's potentially going to be an increased risk of pancreatic cancer in the next 2 decades. And really, there's no good early detection methods. And really, the only successful treatment options we have is if you are resectable and you potentially have surgery for cure. But even then, you'll see some of the statistics, it's not great. Now, when you look at stage and relative survival, patients who are initially diagnosed, over 50% of patients have already metastasized or have disease past the area of the pancreas, which essentially limits their treatment, and they can't undergo surgery because of this. But it really creates a poorer survival when that happens. And so if we're finding most of the patients at a point where they have distant disease, what about those patients who have localized disease? Even with patients who have isolated disease within the pancreas, 5-year relative survival is still under 50%. It's about 41.6%, just going to show how aggressive the cancer is, even if we can do surgery, even if we can treat with chemotherapy, even if we can do all those things. And so further studies and research is surely being done, but even at this point, we see how difficult this disease is to treat, even with all the modalities we have right now. So what are your risk factors for pancreatic cancer? Now, there are multiple different ones. Probably the biggest one that's not changeable is your family history. Now, family history, really your first degree relatives like mother, brother, sister, father, if any one of them has had pancreatic cancer, then theoretically you do have an increased risk of having pancreatic cancer. And we'll talk about early screening and early diagnostic options that can be done, but it is something to be aware of if you are, ever seeing family members with pancreatic cancer. You should be seeking help from either your primary care doctor just to talk to them about it. They can refer you to a genetic counselor or to an oncologist just to go over all of these things. Diabetes, longstanding diabetes is a potential risk factor that's there, typically greater than 5 years, can lead to you having pancreatic cancer. Pancreatitis or chronic pancreatic inflammation can lead to pancreatic cancer. Smoking is one of the changeable risk factors that we have, but really has a very strong association with pancreatic cancer and many cancers in general. So it is always something that's advised to stop as best as you can. Race is something that's also associated with higher rates of pancreatic cancer, specifically in African Americans or Ashkenazi Jewish populations. So if you are of this race, it would be highly suggestive to talk to your doctors to say, is there anything I can do different to monitor or check for pancreatic cancer? Gender, if you're a male, you do have a slightly increased risk than female. Your diet. So diets high in red meat and processed meat, specifically processed meats, those nitrate-based meats like cold cuts or meats that have been preserved. Those specific meats do have an increased risk in data that's shown that potentially increases your risk for cancer and specifically pancreatic cancer. Now, data goes back and forth on this all the time, but specifically in men, it is for sure an increased risk. Obesity is also a risk. So if you're obese, you do have an increased 20% risk of having pancreatic cancer. So losing weight is always an important thing to do to reduce your risks. And then as we get older, our immune system just doesn't function as well to protect us against cancer, and you have an increased risk of developing cancer, unfortunately. So, what are the symptoms? Unfortunately, most people are asymptomatic in the early stages. So when we get a chance to potentially have an ability to cure a patient, unfortunately, we don't even know that they have pancreatic cancer. So incidentally, maybe we might scan somebody if they fall, or they might do something, and that's what triggers the workup for this, which potentially gives patients who do have that early diagnosis a potential chance for cure. But many times these symptoms are actually the late stages of pancreatic cancer. So typically you may see somebody with jaundice, yellowing of the eyes or skin, nausea or vomiting, which is non-specific, but can be correlated with that if you're having all of these symptoms together. Greasy or light-colored stools that float, that's a classic sign. You're going to basically be having gray stool. Epigastric back or stomach pain. This is one of the classic hallmarks of pancreatic cancer. Diabetes, so a new onset of diabetes. If all of a sudden you've been fine and then all of a sudden you've developed diabetes, it's probably worth just talking to your doctor for a workup just to make sure there's nothing else that was missed, or that there isn't something that's going on with your pancreas that's different from what's imagined. You may start losing weight or have a poor appetite. Those are other symptoms for it. Dark urine due to the potential increase in bilirubin in your body. Itchy skin due to deposition of bile salts under your skin from potentially a pancreatic obstruction, and blood clots, which are secondary to you being hypercoagulable, meaning you have a higher risk for making clots when you do have cancer. And so the reason for obstruction, technically, while you develop jaundice, is that typically pancreatic tumors will develop, let's say in the head of the pancreas or some other portion of the pancreas, that will block the area of the bile duct and then cause bile to basically back up into the liver and then go into the system, creating that component of you being yellow or jaundiced. So how do we diagnose pancreatic cancer? So if you see somebody with these symptoms, typically your primary care doctor or whichever doctor you're seeing is going to get a thorough history. They're going to obtain a physical exam. Then they're going to draw some blood tests. Now, these blood tests, there's no specific blood test for pancreatic cancer itself. There are tests that can suggest that, hey, looks like, this thing is elevated, and it could be due to an obstruction of the bile duct. It could be due to damage to the liver. It could be due to some things. But even with these tests, these only gives us information on what's happening in the body, probably secondary to the cancer, rather than being a true diagnostic marker. CA19-9 we'll talk about, but can be used as a tumor marker in patients with pancreatic cancer. But it essentially is a carbohydrate antigen that's released from pancreatic epithelium, biliary epithelium, and a couple of other organs, but can be used to evaluate, response to chemotherapy and other things, but is really not a diagnostic tool. Cross-sectional imaging itself is also used for diagnosis. So you would get a CT scan that looks for a tumor, or an MRI. Both of these things are very important in terms of assessing not only, where the tumor is, but does it have the ability to be removed surgically? And then for further diagnosis, meaning we need to get tissue of it, just because you have a mass somewhere doesn't mean that it itself is cancerous. How do we obtain the tissue? These are the typical approaches, using endoscopic ultrasound for the most part. And you may need to have an ERCP, or endoscopic retrograde cholangiopancreatography, which we'll discuss both of these on the next slide. So in obtaining a biopsy, let's say cross-sectional imaging shows that you have a mass, unfortunately, in the head of the pancreas. One way to assess it is to undergo an ultrasound through the mouth, going into the stomach, and then going through the first portion of the duodenum, first and second portion of the duodenum, and actually taking a little biopsy with a needle under ultrasound guidance to confirm, what this mass is, and then that's sent to the pathologist. If you unfortunately have a biliary obstruction from a pancreatic tumor, then an ERCP can be used, or an endoscopic retrograde cholangiopancreatography can be used to go in through the mouth and essentially access the bile duct and either place a stent to open up that area if there's an obstruction, or even send brushings from this area for further diagnosis if the tumor is higher up and endoscopic ultrasound cannot be done. So let's say somebody's diagnosed with pancreatic cancer. What do you get? You get a pathology report. And typically what it says is what type of cancer is it? Is it a pancreatic ductal adenocarcinoma? Is it a pancreatic neuroendocrine tumor? Is it one of the other subsets that's there? Then it'll go through different characteristics of the tumor, where it was taken, how it was sectioned, how the pathologist looked at it. And then another component of that is discussing whether possible mutation analysis of the tumor should be done. And many times that will be addendum onto the pathology report that will then be discussed by us and our tumor board, or by the pathologists themselves, thinking that, hey, this person needs genetic testing or germline mutation testing to detect, is there a mutation in this tumor specifically, compared to the generic, cancerous tumors that happen in the body. So let's say someone or you're unfortunately diagnosed with pancreatic cancer. There are some terms that you should know in general for cancer, of any type. So typically, most people, when they talk to you, they're going to talk to you about your prognosis. So your prognosis is basically your chance of recovery after treatment. What is your chance of survival afterwards? What is your chance for a cure? Basically depend on the specific type of cancer that you have and your overall health. Neoadjuvant therapy. Now, this essentially means treatment given before the main treatment. So in pancreatic cancer, surgery is essentially our main treatment, where that's really the main option that would allow you for cure. And so neoadjuvant therapy basically means chemotherapy or radiation that's given before surgery to essentially shrink a tumor so that maybe it'll be easier to remove surgically. Adjuvant therapy, this means after the main therapy, so after the main cancer treatment. So in this case, it's surgery. So adjuvant would mean after surgery, you're getting all of these things done, meaning it could be chemotherapy, it could be radiation, or it could be some type of targeted therapy. And then finally, palliative therapy. So palliative therapy many times is really focused on essentially treating a patient's symptoms and reducing side effects and improving their quality of life. So it may not be as focused on cure itself, and it's going to be more focused on symptoms, but it doesn't mean that if you do have a cure from this, it's not something that is also a component of this. It is just the point where things are more focused on, controlling symptoms or improving overall quality of life, rather than focusing purely on a cure. So, when we see patients with pancreatic cancer here at St. Agnes, we basically present patients at our multidisciplinary tumor board. And what that is we take a patient, we go through their entire background, their medical history, and basically create a case presentation that is presented up front for a board of essentially multiple doctors and multiple other people in this huge tumor board, which is typically around 20 to 30 people. So you have medical oncologists, which are typically doctors who treat cancers with medicine or chemotherapy. Surgical oncologists like myself, or hepatopancreaticobiliary surgeons, which I also do hepatopancreaticobiliary surgery, are doctors who surgically remove cancer. Radiation oncologists, and these are doctors who give radiation, which is high intensity energy, typically external beam, energy, which is different from a radiologist. And those are doctors who read images like X-rays, CTs, MRIs. That's the delineation between radiation oncologists and radiologists. I think a lot of patients become confused between both of those doctors, and they are quite different in terms of what they do. And then finally, there are also pathologists there who have a lot of roles, but in this setting, they're typically looking at the microscopic tissue on slides and basically looking at the diagnosis of the cancer. There are also some nurse navigators, coordinators, and social workers that are all intertwined within this multidisciplinary tumor board, so that we can help patients, number one, get the treatment they need, help them with assistance through whatever means of financial assistance, or be able to help them, with many type of social aspects, where maybe they need a ride to the hospital, maybe they need something else. So this is all kind of embedded in our entire treatment approach when we're discussing patients. So what are the different approaches to treatment? And really it depends upon the timing of diagnosis. So when you're diagnosed with pancreatic cancer, you're put into these different categories. You're put into resectable, which means that you have the ability to have surgery and remove the tumor. Borderline resectable, which means you could remove the tumor, but it is in an area that might create a bigger surgery. Locally advanced or unresectable, which means that it's to the point where right now surgery is not a good option and it won't really benefit you. And you need to probably undergo some type of neoadjuvant therapy to see if things will shrink from that. or metastatic, which means that the disease is basically spread and surgery is really not going to benefit you from that standpoint. So, let's say you have, resectable pancreatic cancer. How do you even determine that something is resectable? Like, when can we do surgery first? Because surgery is really your only realistic option for cure. So if it is diagnosed as resectable, we really are looking at where the tumor is in location to specific areas in the pancreas. Number one, we're looking at the superior mesenteric artery, which is the artery that runs behind the pancreas, and then the superior mesenteric vein and portal vein, which is another artery. And then there's other arteries within basically the aorta, the celiac axis, that are also components of the discussion. But typically, we're looking at how the tumor is touching or encasing these arteries and veins to basically put us at whether you're resectable, where you basically have no vein or artery, basically you have no artery involvement. Borderline resectable is basically where you might have some arterial involvement, but enough that, we could get the tumor off the artery and we could reconstruct the vein. So if you needed surgery and you had to, we potentially could, versus it being locally advanced or unresectable, where at this point, performing a type of surgery would not necessarily benefit a patient. And so we're really looking at the anatomy, and the CT scans and MRIs are so important in order to help create these distinctions of what patients are resectable and what patients potentially are not resectable, and what patients are in between or borderline resectable. And even if you are diagnosed and you're what we call locally advanced or unresectable initially, surgery can still be offered after neoadjuvant therapy, meaning therapy before surgery, as long as your tumor is shrinking and you're responding well. So really, what are your surgical options? It really kind of depends upon the location of the tumor in the pancreas. The tumor in the pancreas could be sitting in the head of the pancreas or the uncinate process. And typically, you're going to be undergoing something called a Whipple procedure or a pancreaticoduodenectomy. If the tumor is sitting in the body of the pancreas and maybe abutting one of the main arteries that's sitting in the central location, you would be doing potentially something called an Appleby procedure or a distal pancreatectomy and a celiac axis resection, where you're removing that artery there and hoping for adequate blood flow to be reset through this one artery back into the liver, which we'll get into in details. And then if you have a lesion in the tail of the pancreas, you could undergo a distal pancreatectomy with or without a splenectomy, depending upon, the anatomic reasons or lymph node evaluation that's needed. And then finally, you could undergo a total pancreatectomy, which is rarer and doesn't happen as frequently. But patients with multiple areas of tumors throughout the pancreas who technically are resectable and technically may not be good candidates for chemotherapy, total pancreatectomy may be an option, though it's usually not one of the most preferred options, and we'll get into why that is. So what is the Whipple procedure? I mean, a lot of people hear this. I mean, it is in the name here, pancreaticoduodenectomy, but what it is essentially you're taking the head of the pancreas, the first part of the intestine or the duodenum, the distal bile duct, the gallbladder, and then typically in a classic Whipple, you're taking part of the stomach as shown here, or you're basically cutting all the way up to basically the duodenum, the first part of the duodenum here. And so this is the specimen basically that's being left and sent to the pathologist and being evaluated to see, what are the tumor characteristics, what are the lymph node status, like, what is everything. And then from there, you essentially take this part of the small intestine and bring it all the way up and reconnect that second part of the small intestine to the pancreas, to the bile duct here, and to either the stomach or the first part of the duodenum, depending upon the type of Whipple you're doing. This Whipple itself is a pylorus-sparing Whipple. This is the classic Whipple where you'd connect the stomach directly to the intestines. And each one has their advantages and disadvantages depending upon, who you speak to. But this is a very technically challenging operation, but is, a very good potential treatment option if you have a resectable cancer. And really, this may be your only option for cure if it's resectable, and you can take this thing out and be done once and for all. The Appleby procedure or distal pancreatectomy and celiac axis resection is essentially for tumors that are sitting on top of the celiac axis, which is the artery that's coming off the aorta. And in order to remove these tumors, you're typically resecting this artery that's coming off of the aorta, but this basically supplies blood flow to the stomach, to the spleen, and to the liver. And one inherent component to this is that you do have an arcade or a redundant blood supply coming off of one of the arteries below the celiac axis, or the superior mesenteric artery, that will hopefully feed and retrograde blood flow through into one of the basically arteries that goes then into the hepatic arteries, which then will go and feed the liver. So this is a selective operation that's also technically challenging, but can be an option in patients who are, having a difficult tumor in a difficult location, where you're basically going to remove this part of the pancreas, that part of the artery, and you're hoping that this part of the artery, which is checked preoperatively with imaging and intraoperatively, that you will be able to tolerate having blood flow to your liver from this potential arcade from the superior mesenteric artery. You can also undergo a distal pancreatectomy and a splenectomy if needed. And typically this is for tumors of the tail of the pancreas. And many indications for splenectomy can be that you want to get more lymph nodes. Technically, it's an easier operation because you don't have to worry about the blood supply. And so my preference most of the time for an adenocarcinoma is almost always a splenectomy along with the distal pancreatectomy, just because you get a better lymph node yield. Things are a lot easier from the operation. The operation is a lot quicker. And really all you need from the splenectomy is that you'll need some post-splenectomy vaccines. Now, bigger discussions can be had on that, but my personal preference would be to remove the spleen, and there are indications where we may not, but typically this is the approach for most adenocarcinomas. And then finally, a total pancreatectomy for somebody who has multiple lesions within the pancreas. Now, the biggest caveat to this is, if you remember me talking about the pancreas, it involves effort in digestion, and it has a significant effect in your hormone balances, including blood sugar management. So once you remove this, you can become basically a brittle diabetic, where you have a very hard time controlling your blood sugars. It can be very challenging. I know some patients who have, we have had to do total pancreatectomies and they do have a good regimen, but from a lifestyle standpoint, it is very difficult because they can't eat a lot of things that they used to eat. They can't, eat things that maybe will create big spikes or fluctuations in their insulin or in their blood sugar levels. And so from that standpoint, yes, it's not ideal, but the other option is, you potentially die from pancreatic cancer, which, I guess most patients would probably take lifestyle modification over passing away from this. And that's why it is definitely an option in select patients in select situations. So let's say, unfortunately, you can't have surgery first. What are your options? So let's say the tumor is borderline resectable, or it is, locally advanced or unresectable. You have options for chemotherapy and radiation beforehand. And what chemotherapy essentially are drugs that are used to kill cancer cells. And radiation itself basically is the use of high energy X-rays or other particles that can basically be used to destroy cancer cells. And these are given basically, again, as we spoke, neoadjuvantly or before surgery. So the typical standard approaches, now there are different types of neoadjuvant chemotherapy that can be used, but the main approaches that we use for most patients are FOLFIRINOX. Now this is a combination of multiple different chemotherapy drugs. You can see the acronym here, but it's folinic acid, which helps the 5-FU or fluorouracil work better, the irinotecan and oxaliplatin, which are all components of this chemotherapy. And it's a pretty strong and aggressive regimen that we reserve for patients who are very fit. Another option is gemcitabine and NAV or albumin-bound paclitaxel, or Abraxane is a brand name for it. This typically is a albumin-bound paclitaxel that basically delivers the drug more effectively to the pancreas along with gemcitabine. And studies have basically shown that these are equivalent in overall survival over the past 3 to 5 years from treatment. Now, initially it was thought that FOLFIRINOX, because it was more strong and more aggressive, it was, the better approach. But in reality now, both of these are very good approaches. And really selecting which one will work for you is really dependent on your oncologist and your performance status and multiple other components of your health. So let's say you start neoadjuvant chemotherapy. So you have a cancer that is borderline resectable at this point, and you say, you know what, maybe we should give chemo to shrink things down and get it to the point where it is resectable. So you'd either start FOLFIRINOX or gemcitabine and Abraxane, and then essentially treat for a certain amount of time, which is typically 4 cycles or for 3 months, and then assess the response after chemo with imaging and laboratory work, which typically is a CA19-9. So after 3 months or 4 cycles of chemotherapy, we basically meet again in our multidisciplinary tumor board and we basically discuss everything. We say, did the patient have a good response? If the tumor has shrunk down even more, great, maybe we should continue riding the wave of chemo. Or should we go to surgery? Maybe the other option, say, hey, the patient is the fittest they can be, the tumor has shrunk down, seems like a more straightforward surgery, great. If a patient has not had any response or side effects, if the patient has not had any response to the tumor, or they've had some side effects, maybe that means we need to switch the chemotherapy, either from FOLFIRINOX to gemabraxane, or vice versa. The other option in discussion could be potentially adding radiation to the mix. Now, the data is kind of mixed on whether or not it truly helps, but it is another option in select patients that may help significantly. And then finally, let's say there's no response and everything's kind of the same and the patient was still borderline resectable. Should the patient go to surgery if they just can't handle chemo and they're like, I can't do this anymore? Now, surgery may be an option in borderline resectable cases. However, the caveat to that is that, there may be a more extensive operation required, meaning we would have to resect a portion of vein. As you can see, here's a pancreas tumor sitting here on the vein. This vein will probably need to be reconstructed, whether it needs to be completely resected and reconstructed, or if we can take a piece off of it, or we can put a patch onto it. This just essentially increases your potential complication risk for the surgery, but itself can be done and is done in select patients, especially when they can't tolerate chemotherapy and they have a good performance status and can tolerate an operation like this. So it is another option. So what happens if the tumor itself hasn't stayed the same, but has actually unfortunately gotten bigger with chemotherapy? So again, we reassess everything in our tumor board. We talk with everybody. First thing we talk about is, should we change our chemotherapy? And typically we are trying to change the chemotherapy when that happens. Next, do we add radiation? Again, we explain that, look, the data is mixed on the results. Not sure if we should or shouldn't do it, but in select patients, it may benefit them. And then the last option is, do we go to surgery now? Because maybe this is the only potential option for a patient for cure if we can remove the tumor at this point, because we have the ability to do surgery still and it hasn't spread further past then. So what happens if, unfortunately, the tumor has spread more than this? Let's say, unfortunately, it spreads to your lungs or your liver, and now we're seeing the patient and gotten cross-sectional imaging after 3 months of chemotherapy. Again, we talk about this in our tumor board. We basically now start discussing palliative treatment options. Now, at this point, it's very difficult to cure a patient with metastatic pancreatic cancer. If you saw in the harrowing statistics from before, really treating pancreatic cancer once it's metastatic is very, very challenging. And so really, palliative treatment, which means that you're trying to treat symptoms first rather than a cure, is many times an option. And that doesn't mean that you're not going to get chemotherapy, because the chemotherapy itself may be a palliative treatment, which shrinks down the tumor somewhat. But at the same time, there is a risk benefit and a risk balance to say, is this beneficial for a patient's quality of life? Is this beneficial for their, long-term health? And, will this help them at least, live a better, life? Because just because you can treat the tumor and you're miserable treating the tumor doesn't mean that we should treat the tumor. Another discussion point is whether or not patients should go into clinical trials. Now, this is always dependent on if a patient is a good candidate for a clinical trial, whether they're willing to do this. And most clinical trials are good in the sense that they will always have the standard of care versus the new treatment approach. So it's not like you're not going to get the standard of care for your treatment, but it does give you the option to have something that could work in you that is a new novel therapy that may miraculously help treat you or cure you. Targeted therapy or other options. Now we can get into specific mutation status of your tumors and whether your tumor is microsatellite unstable and you could respond to immunotherapy. That's probably a whole other topic, but targeted therapies could also be discussed at this time as well. And then finally, hospice. Now, hospice, I think when people hear this, they say, oh my God, I cannot do hospice. That just means they're going to kill you. And that's really not what hospice is. Hospice is very similar to palliative treatment, where this place where you go for hospice, and hospice could be done at home. So it could be a home hospice. It could be a certain location that you go to. What it's really focusing on is palliation or symptom control for patients who have aggressive cancers or cancers that have spread. that essentially treats their pain, it treats their symptoms, and it also helps them emotionally and spiritually, basically with needs at the end of their life. And so really hospice care prioritizes comfort and quality of life, and basically reduces pain and suffering. That's the main goal. Really, if cure happens in this place at this point, it rarely does, because you're not really on chemotherapy in hospice. But at the same time, the goal at this point is a very different goal, where we're wanting to make sure your quality of life is paramount and it's the utmost important thing, and that's what we're focusing on in hospice. So hospice is not a death sentence. It just means that you are going to be treating your symptoms rather than potentially treating the tumor or treating for a cure. And that's basically the difference. So now getting into all this, like, what can we do to reduce our risk of pancreatic cancer? So prevention is a very challenging thing in pancreatic cancer, because many times the diagnosis is so late. You want to avoid ever developing pancreatic cancer. So one of the biggest things is maintaining a healthy weight. Obesity has a 20% increased risk of pancreatic cancer. Losing weight is probably one of the biggest keys. And within that, it's eating healthy, eating healthier foods. I mean, we all know when we go in the grocery store, stuff that's packaged or has labels that are bigger than a paragraph typically are probably not the most healthy thing to eat. And so trying to eat whole foods or foods that are just like of a couple ingredients, those are probably much better for you, and not only for longevity, but would potentially improve other issues with your health, reduce your risk of cardiac disease, reduce your risk of other cancers, and in general will probably help you maintain a healthier weight much easier than eating processed foods or other foods that are just not healthy for you, that we all kind of know of. Now, I'm not saying that means just completely eliminate ever eating, something that's delicious like fried chicken or pizza or other stuff like that. But at the same time, eat it sparingly. Don't eat, a bucket of fried chicken every day. Yeah, you can have a couple of pieces of fried chicken once a week. You can have, pizza maybe once every other week. You can have these things once in a while. But at a certain point, you probably don't want to be eating certain things like this every day. And so that's where you use them more as a treat rather than your actual main diet. Stopping smoking is probably one of the biggest ways you can reduce your risk of pancreatic cancer. And now, again, it's easier said than done, but that's probably one of your biggest modifiable risk factors, where if you were able to stop smoking, that significantly reduces, number one, your risk for cancer, but also improves multiple aspects of your life. And so, if you are seeking assistance with smoking, we can talk about this after the webinar, but it is something that if you're ready to quit, that's the ideal time. And you have to be motivated to quit. Like everybody's going to tell you to quit, but if you're not ready to quit, you need to be ready to quit to be able to stop. Limiting your alcohol intake is also another big risk reduction strategy, because alcohol itself can cause inflammation of the pancreas, and it itself, theoretically is a toxin that you're giving to your body that your liver has to clear. And so if you can minimize that, that to me is something that can potentially reduce your risk as well. Now, patients who do have a family history of pancreatic cancer, screening now has been recommended in many of our cancer guidelines, and there's been, more recent papers that have suggested that adequate screening for patients with a family history of pancreatic cancer has been shown successful to catch patients with early pancreatic cancer and potentially cure them. And so you would be undergoing endoscopic ultrasounds or MRIs maybe every other year for diagnosis or for essentially screening. And within that, you really need to talk to your doctor about this to basically go through and say, am I a candidate for screening evaluation? Now, one of the other things is looking at your mutation status that you may have, and many patients may have genetic mutations such as the BRCA mutation, which can have an associated risk with pancreatic cancer as well. And the BRCA mutation actually doubles your lifetime risk for pancreatic cancer. So if you or anybody in your family does have this potential mutation, it is something to be aware of, and it is something to talk about your oncologist or the way you were diagnosed to say, maybe I should be screened and tested for this mutation, to decide whether, screening may be beneficial for you if you potentially do have this mutation. And, really, there are multiple other mutations that are there in the literature, which again have a certain risk of pancreatic cancer. And that's where understanding your family history really is important in order to suggest whether or not you would benefit from screening or not. So in conclusion, pancreatic cancer, again, it's a very challenging disease. Now we have research that's ongoing for diagnosis and treatment. Specifically, a lot of us are looking at early detection. I was in a research lab where we were trying to do early detection, and we were trying to figure out some type of blood test that could detect pancreatic cancer early. But unfortunately, many of these things are not coming to fruition. We will test it and do it on animal trials, and then in human models, it may not work very well. So it is something that's actively being researched, and hopefully is at the forefront of new research that's coming out. Targeted therapy is changing. We do have many different types of targeted therapy. Immunotherapy has been approved for certain types of pancreatic cancer. It is something that is definitely another approach to treatment that is slowly expanding in terms of the knowledge and literature that we have for it. And then finally, personalized treatment approaches are very important because every patient's tumor is different. Some patients may have a certain mutation in their tumor, other patients may have a different mutation. And if we can detect what type of mutation a patient has, that will help us better treat and even potentially cure patients with certain types of pancreatic cancer. Another really important thing about pancreatic cancer is, as a patient, you should for sure go to a center where there's a multidisciplinary approach to treat the disease, because this is a very challenging disease, and it includes multiple facets of multiple different experience specialties that are really talking about what is the most beneficial route for a patient. Because where a patient may not be able to have surgery in the beginning, if you've got an excellent medical oncologist and radiation oncologist who are going to shrink the tumor down to a point where now it's surgically resectable, now you've got surgery to potentially allow a cure for this cancer. And so that's where this multidisciplinary approach is really paramount in treating the disease. And here at St. Agnes, we really have an excellent multidisciplinary approach to pancreatic cancer. And I'm constantly talking to colleagues. I mean, I was making this presentation and I was just thinking about how many times people were messaging me or pinging me about a patient saying like, hey, I'm going to do this. Hey, can you see this patient? Hey, what do you think about this? Should we present the tumor board? Should we do this? And it's like we're constantly talking about patients every day. And when you have that and you have a team approach to all of this, that is where you have your greatest success for potential cure. And one of the biggest plugs that I think nobody talks about at St. Agnes is that we have free parking. You can come anywhere and park. It's great. There's a free valet in the front. You can do whatever you want. I mean, I remember going to other centers and having to pay, $15 to go see a doctor, which top of your copay is very frustrating. But here at St. Agnes, there's free parking, and I think that's something that's really not talked about as much as it should be. So I wanted to thank you all for listening into this webinar, and I'll take any questions about anything.
That was great, Dr. Kadri. A lot of great information presented there. So for all the folks on the call, if you do have a question, please go ahead and open that Q&A box and type your questions into the chat there. Again, that's only visible to Dr. Kadri and myself, not the entire audience. So please feel free to ask your questions. Yeah. Dr. Kadri, do you want to go through the chat, or would you like me to read them out?
Sure. No, I'll read some of them. So
Okay.
One person asks, my mother died of pancreatic cancer. I'm so sorry. That's so difficult. My grandfather passed away from pancreatic cancer, which is why I'm striving to cure this and treat this. But she says, or he or she says, I have cysts on my pancreas that are being monitored. Should my daughters who are in their 30s get some type of baseline screening done now? I would say that is probably very reasonable. And from that standpoint, it kind of depends upon what type of cysts you have and what the potential risk of malignancy is for those cysts. So I would for sure say that your daughter should be getting some type of baseline screening done as well. And it also kind of depends upon when your mother passed away, what was her age, a lot of other characteristics of that. But I would say for sure, I would bring up this discussion with the person who's monitoring you for your pancreatic cyst, just so that they understand this as well. And then they can kind of broach the subject and discuss other things with you. Next is the BRCA test a blood test? Yes, it's a blood test. How do you get BRCA testing done, and does insurance cover it? Now, the insurance part is a tricky thing. So it is a blood test, and typically people are getting this done for a couple of reasons. If a patient is diagnosed with cancer at a certain young age, basically less than 50 or less than the typical age where patients are typically getting this type of cancer, many times this kind of prompts a genetic workup or genetic testing for this. Now, the other component of patients having, BRCA testing is if you have a strong family history of cancer. Now, that will kind of be dependent on, number one, the doctor that you're talking to, and number two, what the insurance company will decide. If they say that, what, looks like you've had a significant amount of family history of cancer, it is worth getting genetic testing, but you will have to have a certain criteria or certain family members that are being diagnosed with cancer or being diagnosed with BRCA mutations for you to have that done. Now, I don't know how specific insurance is for that, but it may be a good question to talk to your doctor, who then may prompt this to the insurance companies.
And just to clarify that a little farther, sorry. When you say strong history of family or strong family history, would like your mother having cancer be sufficient, or do you need like multiples?
So that, that is always a difficult question in terms of screening. Is definitely, if your mother had it, screening is definitely going to be allowed. Now, the biggest question is if they checked your mother for, genetic mutations, and if she potentially does have she potentially has genetic mutations, then at that point, insurance companies may be more inclined to say, all right, we need to check you as well. So it really kind of depends upon the number of family members that have cancer. If they have mutations as well, that would prompt you to be able to get mutation analysis. But it is, I honestly don't know how the insurance companies handle that. That's a really good question that maybe is, better talk to with an insurance specialist.
Okay, great. And I'm sure it does vary from insurance to insurance too.
Yeah. Next question is, eating processed meats 2 to 3 times a week considered too frequent? I would say that there is more and more data coming out that shows that nitrate-based meats or nitrate-preserved meats like cold cuts has been shown to increase your risk for cancer. I would say it probably is too frequent. There is a risk benefit from that. If you think about people who develop cancer, it's typically a 2-hit hypothesis where you have people who have, poor genetics, where their genetics are just not good at protecting patients against cancer, and you potentially have an environmental factor that's causing cancer. So in this case, like, let's say your genetics are great, probably eating, meats, preserved meats 2 to 3 times a week may not do anything if your genetics are strong. But let's say your genetics are not great at protecting against cancer, and you're eating these nitrate-based meats, which are potentially increasing your risk for cancer, then potentially at that point, it increases your risk for cancer. So really, it's always patient-specific, patient-dependent. I would say if you can avoid nitrate preserved meats in general, that's probably your best bet. But I would probably say 2 to 3 times is more than frequently, more than it should be. But really, I think you have to assess your risk, and you have to assess, your lifestyle and all those things, and make a decision on your own. But from just looking at it from a medical standpoint, I would say it is probably too much. Could pancreatic cancer affect your blood pressure? Now, it really does depend. Typically, pancreatic cancer is not necessarily, high blood pressure or low blood pressure is not necessarily a sign of pancreatic cancer itself, but especially if you have a pancreatic neuroendocrine tumor, it can create some hormones that potentially, lead to changes in your blood pressure, changes in your physiology that could lead to that. But typically, blood pressure is not, changes in blood pressure are not from pancreatic cancer, and vice versa. High blood pressure typically does not cause pancreatic cancer. So it says, next question is, can you go over the symptoms as far as bowels, what to look for? So typically most patients are having epigastric pain or abdominal pain, really in the upper part of the abdomen. You will have acholic stools or stool that are gray. And the other component in terms of your intestines would be, your urine would be very dark. You would have jaundice, meaning your eyes would be yellow. And then typically patients will be having chronic diarrhea as well. If let's say a component of your pancreas is blocked, or, it's taking over a part of your exocrine pancreas from the tumor, then you may not be producing enough pancreatic enzymes to help digest food. So diarrhea could be another symptom from an intestinal standpoint that could be secondary to pancreatic cancer. Can problems with the gallbladder, next question, can problems with the gallbladder be associated with or lead to pancreatic cancer? Now, the gallbladder itself is intertwined with the biliary system, and which is also intertwined with the pancreatic system. Gallbladder issues themselves don't necessarily lead to pancreatic cancer, but having chronic gallbladder inflammation or chronic, cholecystitis does increase your potential risk for gallbladder cancer. Now, it itself, typically when we look at cancers in what we call the hepatopancreatic biliary region, they're all kind of correlated because they all kind of share similar types of epithelium that's there. And so while gallbladder cancer itself is separate from pancreatic cancer, it is again a very aggressive cancer and that can be potentially increased or have an increased risk with gallbladder issues or potential episodes of cholecystitis or chronic biliary colic. So while it's different than pancreatic cancer, it is something to be addressed. And I would go talk to your doctor or your surgeon to assess things about your gallbladder if you are having problems with that. When you say pain in the upper abdomen, would that be right or left quadrant or mid upper abdomen? Essentially, it's mid upper abdomen. So it's like literally right under, if you feel your breastbone, you'll feel this little process called the xiphoid process. Most patients are having what we call an epigastric abdominal pain, which sits right below your breastbone. So if you feel the center part of your sternum there, this is basically where most patients will initially feel pain. And the pain is very specific. Many times it's going towards the back. Like it's not really going towards the front, it's going towards the back. That's what most patients basically say is happening for the pain. But the classic picture of patients with pancreatic cancer, unfortunately, is something called painless jaundice, where patients have no pain and they just present to their doctor with jaundice or yellowing of the eyes and skin. What efforts are being made to, next question, what efforts are being made to develop early screening options? Now, there are a lot of efforts. I mean, there are countless studies, I can't tell you enough, that are looking at, number one, trying to find a blood test that potentially could be a good marker for pancreatic cancer for diagnosis. Potentially what type of imaging modalities are good for pancreatic cancer. I mean, these are all in the works for a lot of stuff. And, there are things that get a lot of traction. And then unfortunately in human studies, there's nothing that has been truly shown to be beneficial at this point. But, there's always something at the forefront for everything. Now, I mean, I would say that as, I was in a lab that literally what we were looking at were biomarkers for pancreatic cancer. So it is something to understand that there are certain labs with like 10, 20 people who are dedicating their research efforts to this. So I would say there are definitely things on the forefront. It just depends upon whether or not they will work or not. And that's what we pray and hope will hopefully come to fruition through clinical trials and other studies. Next question. My father is now 76 and was diagnosed with pancreatic cancer last December. I'm sorry to hear that. He had surgery first in February this year with a tip. 40% of his pancreas and spleen were removed. He started chemo in April and rang the bell October 15th. Prior to the diagnosis, he would, I assume rang the bell is, prior to the diagnosis, he weighed 195 pounds. His weight went down to 130. He's trying to gain his weight back and is at 140. Is there a chance he will gain most of that back? The hardest part about cancer in general is that cancer itself consumes all of your nutrition. And that's why many times patients lose weight and, reduced appetite. You have a lot of other issues. Now, a good thing is that it seems like he's gaining weight. And, the most important thing I would say is that it's a slow progression to getting back to your weight. It's not going to be like all of a sudden, overnight. It's just going to be, said, ring the bell when you're done treatment. Oh, okay, when you're done treatment. Oh, you ring the bell. Okay, got it. So he finished his chemotherapy in October. Yeah, I would say he's still early. I mean, this is only 1 month out of chemo. That's excellent that he's even gained 10 pounds in the course of a month almost. So no, I would say he's on a good track. You're not going to gain weight back. You're not going to get all of your strength back. I mean, chemo takes a toll on your body. It's not a simple thing. And so it's just going to take time. I mean, that's great that he's gained 10 pounds back within a month. I would say that's excellent. But yeah, it'll take time. Has there been any studies showing, next question, has there been any studies that show a link between pancreatic cancer and having a sweet tooth, overindulging in sweets? Now, this is a good question. One of the big things in cancer that's being evaluated are what we call metabolomics, where people look at the metabolism of cancer, where they're looking at whether or not, high amounts of sugar or high amounts of glucose are actually triggering people to have cancer, because technically cancer cells feed off of glucose, right? We all kind of know that, and that's a component of this. But does it mean that if you eat a brownie, you're putting yourself into having cancer, you're putting yourself into, having, some type of other bad thing happen? Not to say that, brownies are delicious. I love brownies, right? But at the same time, there's always a balance in what you eat that's sweet and what's not sweet. Obviously, if you eat a brownie every day, it's not great, but once in a while it's fine. But I don't think there's any specific data suggesting that a sweet tooth itself puts an increased risk at you having cancer, and specifically pancreatic cancer. But there is research on the forefront that's looking at, cancer and metabolomics and saying, is there a certain type of diet that's better than others that potentially reduces your risk of cancer? And what things can we, mitigate or change in our metabolism that potentially reduce our risk for cancer? So, it's a good question. I think that a lot more research has to be done. And, I really don't think that right now there's a true answer for that.
All right, looks like that's all the questions we have so far. I just had one other point to clarify, Dr. Kadri. For a new patient coming to your office, is a referral needed to set up an appointment, or do they just need to call the number and get started?
Again, that really depends upon your insurance, unfortunately. I would say I am always happy to see patients, whether or not, they have a referral. The biggest component of that is that, sometimes if there's no referral, some insurances will not cover the visit. And, many times what will happen is we'll try and delay. I shouldn't even be saying this. My manager is going to kill me, but she's going to, sometimes we'll delay, payment for the thing just to ensure that the insurance will be covered. But I would say the safest thing would be to, get a referral if you need a referral. Like, you'll know based off your insurance. But if you don't need a referral, happy to see anybody in clinic to discuss this. And then, again, we'll present your case in our multidisciplinary tumor board. Is the MRI with contrast? Yeah, typically the MRI is with contrast, and it's a specific type of MRI where you're looking at, so let's say you get an MRI for diagnosis, even surveillance screening, you probably should get IV contrast, but typically the MRI is a very specific type of MRI, which is looking at different phases of blood flow, meaning you're going to look at the venous phase or portal venous phase, which looks at certain blood vessels that are sitting behind the pancreas, the arterial phase, where you're looking at certain blood flow in the artery that's there. And so that specifically, you would need contrast for your MRI in order to have better images for, number one, diagnosis and for surveillance screening. Next question. I have a J pouch, which is a pouch that happens if you've had a total abdominal colectomy, and you basically are creating this pouch of jejunum down in your pelvis. My sister had an ileostomy and pancreatic cancer. She couldn't manage her hydration when in chemo. I have a yearly EUS because I have a BR1IP1 mutation. I'm concerned if I develop pancreatic cancer, hydration will be an issue. Is hydration normally a problem with chemotherapy? Now, I'm sorry, you're going through a lot of things and you have this mutation. It's definitely difficult. But, it kind of depends. A lot of times, hydration itself can be a problem for some patients. Typically, many patients are getting IV bolus bags of fluid, especially if you have chronic nausea and vomiting from the chemotherapy. But that, God forbid you develop a pancreatic cancer. But at the same time, a lot of that can be mitigated in the discussion with your medical oncologist, who might say, like, let's try this type of chemotherapy regimen to reduce your risk of dehydration, or let's always give you a certain amount of fluid per treatment just so that you never get dehydrated. But it can be potentially a problem. But, hopefully, that doesn't happen to you, that you develop pancreatic cancer.
All right. I think that's all we have for today. So if you do think of any additional questions or you'd like to get more information, you can reach out to Dr. Kadri's office, which is Ascension St. Agnes Maryland Surgeons, at the number shown on your screen, which is 443-574-5800, or you can find more information on ascension.org. Dr. Kadri, do you have any final words before we close out for this evening?
No, there's one last question. My mom had colon cancer and was free for 19 years and then had pancreatic cancer. What is my next step? it kind of depends upon whether your mom has any, genetic mutations, assessing. Oh, we got a couple more questions. Uh, your next step would be, it depends upon, the reasons for pancreatic cancer. If there's a genetic syndrome, many times colon cancer and pancreatic cancer, something specifically called Lynch syndrome, can be a possibility. Now, there is a big, gap in the next cancer, but at the same time, that may be something to look at. I would surely, determine what depending upon when your mom's age was when she had these cancers, it may be worth talking to your doctor to see if screening may be available for you. And then next, I'm 54. Next question. 54 on occasion experience bloating at times, and because of my 76-year-old father had pancreatic cancer, it causes me to wonder, pause, should I be concerned? Now, bloating in general, it isn't really a specific symptom. Now, I would say that, you do have your father having pancreatic cancer at 76 is a concerning risk factor that's there. One important thing would be to discuss this with your primary care doctor to say, hey, I'm having this bloating. Maybe I should get a CT scan just to confirm that there isn't anything wrong. Even at the minimum, an ultrasound just to look at everything. But I would say my preference would be a CT scan of the abdomen and pelvis just to make sure there isn't anything going on. I mean, that already to me is like a potential, use to at least rule something out with a CT scan. So I would talk to your primary care doctor with that. Another question. I don't have a question. Okay, I just wanted to say I lost my father in 2016. My family had zero information. This was very informative. Thank you. Let's see. Is a CT or MRI preferred? Each one has their advantages. I think either one is fine. It depends upon the type of lesion. If the lesion is cystic, many times an MRI can be better. If the lesion is solid, sometimes a CT scan looking at the blood vessels makes it easier. Both are okay. I mean, it just depends upon the type of lesion. So no one is more preferred than the other.
Great. And we did have one question in there about the recording for this session. And yes, it is being recorded, and we will have the link emailed out within 48 hours after the presentation.
I mean, final thoughts. I think pancreatic cancer is a very challenging disease, if you haven't heard that from everything. And, when I was making this talk, I was like, I could talk for hours on this, unfortunately, because of all the different treatment modalities. Like, this is just kind of scratching the surface for a lot of things. So, again, if you do have questions, and if you do know somebody, or unfortunately you're diagnosed with pancreatic cancer, I'm happy to answer questions, see you in clinic, talk about these things just for further options. But, they're just understand that there is help, and there are a lot of options available. And, here, especially at St. Agnes, we have this multidisciplinary approach where you've got like 20 doctors at all times kind of talking about your case and really reviewing everything. And to me, that makes me feel comfortable to say, in general, like, let's say not just that something can be missed, but in general, you've got opinions of people who will say, this opinion here. Then one person might say, no, he needs to have surgery. The other person might say, no, I don't think he needs surgery. Maybe somebody in the middle and say, maybe you should just do chemo. And that's always a great discussion to look at the risk benefit for things.